installment of the ClinGen Clinical Genomics Career Panel Series. We'll just wait about another 30 seconds or so for additional attendees to get logged in, and then we'll get started. All right, so it looks like our participant list is slowing down, so I will go ahead and get started with some housekeeping information. Let me put this in presenter mode. All right, so just to remind you, this is part of an ongoing series. We've already had 2 panels over the last few weeks. If you missed those or wanted to go back to refer to them in any way, the recordings are available on the clinicalgenome.org website or on the ClinGen YouTube channel. Today, we are going to be focusing on physician clinicians. And then just as a reminder, we do have 2 additional panels coming up, one focused on research and other opportunities, and one focused on stepping stone opportunities. Thank you again to everyone who provided questions in advance for our panelists as part of registration. But even if you didn't, or if someone says something that inspires another question in you, you can always type them into the Q&A box there at the bottom of the screen, and I will read them out to the panelists as they come in. So don't hesitate to do that. And then before we get started, we just want to get a little information about you guys as an audience so that our panelists can address you properly. So the first question has popped up on the screen. As of fall 2021, are you a student? If you would just take a moment to let us know who you are, we would appreciate it. All right, and it looks like most people in the audience today are undergraduate students, but we do have at least one person who's currently a medical student, some individuals that are recent graduates and kind of thinking about what are their next steps in their career, etc. All right, I believe we have maybe 2 more questions. The next one, how familiar are you with medical genetics specialties? There is a typo on the screen, but answer it as though, how familiar are you with medical genetics as a clinician specialty? All right, most people are at least somewhat familiar with it, but there are a fair number of people who have not really thought about this as a career option before, so a few new people as well. All right, then last question. Have you applied or are you currently applying to medical school? All right, so most people have not applied to school yet, but we do have at least a few people who have or are in the process of doing so now. All right, great. Thank you for humoring us with that, but that just helps us to get to know a little bit about who we are speaking with today. So with that, I am going to turn it over to Annie Niehaus, who is currently a resident in the clinical genetics specialty, and she can walk us quickly through a little bit of the background about clinical genetics.
Great. Thanks, Erin. As Erin said, I'm just going to briefly summarize kind of the process of getting involved and going through a genetics residency, as I'm in one currently. So the application process is fresh in my mind. And then the rest of the panelists will speak more towards their daily life of what being a clinical geneticist will actually look like. So as most of you probably know, clinical geneticists are physicians. They go through medical school and training, and they care for patients in a clinical manner related to genetics. So this involves evaluation, diagnosis, management, counseling, and treatment of a variety of inherited conditions. And medical geneticists really see patients from all ages, from birth to adulthood, not just kind of within the pediatric or adult specialty. They can see all age ranges. And they often work very closely with other specialties. So with subspecialties, neurology, cardiology, or most commonly just within the primary care pediatrics as well. Next slide. So just to briefly summarize the path to becoming a clinical geneticist, since it is a medical specialty, it does require going to medical school. To enter medical school, you have to take certain course requirements. You don't need a particular major, but you do need to fulfill the requirements, which are somewhat changing, but you can find those and talk to your school counselors for those, roughly taking a couple introductory courses and all the science courses, biochem, I believe statistics is now a requirement. Essentially, then once you go to medical school, the residency process is what I mostly wanted to focus on because that has shifted over the years and might be an area that continues to shift as there's different pathways to entering into a genetics residency. But it does require going to medical school. And then in your 4th year of medical school, that's when you apply to residencies. So that's in the 4th year, you apply through a system called the match. Next slide. So the requirements for a genetics residency and to be eligible to be board specialized in medical genetics and genomics is at least 1 residency year in a primary specialty, followed by 2 years of medical genetics and genomics training in a genetics residency program. So this means that there's a couple of different ways to kind of get through this training process. The first option here is to apply through a combined program, pairing both the primary specialty and the medical genetics training together. This is more of a new pathway, but is becoming increasingly more popular. Most of these programs are 4 years long, and we'll go over a few. The second option is to apply to a genetics residency after a full primary residency or part of a primary residency. Again, you must complete at least 1 year in that primary specialty, but primary specialties can range in length. So it can be anywhere from 1 year to a full 4 years. So those are the 2 different pathways, and I'll go through those a little more. So the most common primary specialty is pediatrics. That's a 3-year categorical pediatric training program, is 3 years long. There's multiple different medical specialties, as you're aware. So you could also go through internal medicine training, OB training, family medicine. These all vary in length, but roughly 3 to 4 years. And after completing some of that training, you would be eligible to apply to the medical genetics residency. Again, program requirements vary. So some medical genetics residencies accept applicants after just 1 year of primary training. So after just 1 year of pediatric training or medicine training. Others require you to finish the entire primary specialty. So they want you to finish the full 3 years of pediatrics. That information can just be found on individual program websites, and it does vary. So that's one pathway to be eligible for a genetics residency. The other pathway is the combined programs, which again are becoming more popular. These pair the primary specialty with genetics. So you go back and forth in the different training programs. They are different training programs and different residencies. So you do switch back and forth between them. And it varies by program, how often you switch. I would say most in your 1st year, you do entirely peds. And then from then on out, you switch back and forth between pediatric and genetics every 3 to 6 months, or between medicine and genetics every 3 to 6 months. So right now, the 2 main combined programs are pediatric medicine and medical genetics, and internal medicine and medical genetics. And those are both roughly 4 years long. A few programs have additional research years built in and might be another year or 2. There's a little bit over 23 programs right now, a little over 20 programs in peds and genetics, and just a couple medicine and genetics programs. The number of pediatric and medical genetics combined programs is growing as the years go on. So likely when many of you are applying, if you were to apply to those programs, there might be more than 20 at this time. And once you complete the genetics training, then you're eligible to take your board exam through either of these pathways. Next slide. All right, this is just a summary table summarizing the different ways to get into genetics. Again, the main thing here to emphasize, though, is just that there's a couple different pathways, and the training pathways have shifted over the past couple of decades. So it's really just important to reach out to your medical school advisors and to others in the field to get the most up-to-date kind of advice on the best way for you. And I think that might be, oh, okay, a couple more slides. Just mostly the rest of the panelists will speak towards this, but GenX professionals work in a range of different, I apologize, different institutions, different settings. You can work for private genetic testing companies, work in a hospital setting, work for consulting. I believe most of the panelists here are working in a medical facility or institution. Most commonly, this information is coming from the American College of Medical Genetics. Most commonly, medical geneticists work at a non-commercial public institution, like a hospital, academic medical center. Next slide. And then just lastly, a plug for joining ACMG. Student membership is free, and that's where a lot of this information comes from. They have a lot of great materials on there, a lot of great education materials as well. Great, thank you. That's it.
All right, thank you so much, Annie. And we will hear more from Annie in the final panel of this series, talking about stepping stone opportunities. So with that, I am going to allow each of our panelists to introduce themselves to you. Again, because we are having physicians join us today, I believe some people that were originally slated for the panel are on call, and so they may not be here right now. But we thank very much the people who are here. So I will stop sharing. I will call on each of you by name. And I just ask that you briefly introduce yourself, say where you currently work. I know a number of you do have split responsibilities between clinical and research. So if you want to say a word about the complete picture of what you do, and then we can go from there. So I will start with Maya.
Hello, and thanks, Erin, for including me in this great event. So I'm Maya Chopra. I'm a clinical geneticist working at the Translational Neuroscience Center at Boston Children's Hospital. And the focus of the Translational Neuroscience Center is to develop therapies for rare genetic disorders and to bring them into trials. I trained as a clinical geneticist and pediatrician in Sydney, Australia, and have practiced and worked both clinically and research in China, France, and it's a pleasure now to be here. So very nice to meet you all.
Thank you. Let's move to Constance.
Hi, I'm Connie Smith-Hicks. Thanks for inviting me, Erin. I'm a child neurologist by training, so my path is very different from perhaps the paths that will be shared today. I am here at the Kennedy Krieger Institute, which is a part of the Johns Hopkins Medical Institution. And I did my training in pediatrics, neurology. I did a PhD in genetics. And some neuroscience work.
All right, thank you. Bradford?
Hi, I'm Bradford Powell. I am one of those folks, as Erin mentioned, who can't decide one thing to do, so I do some research in some clinic. I am in the Department of Genetics and Departments of Medicine at an academic medical center at the University of North Carolina at Chapel Hill. I trained in pediatrics before training in medical genetics, although interestingly now I'm doing a fair bit of adult genetics as well. That's part of the training program in medical genetics, is that you are trained to see folks regardless of age. On the research side, I'm interested in the data science of genomic sequencing. And so those are the aspects that I look into. And again, it's a great career for people who want to combine a little bit of that.
All right, Suma?
Hi, Erin. Thanks for inviting me to be on this panel. I also have a little bit of unusual career. I trained as a ophthalmologist in England and then came over to the US to do PhD in molecular genetics in ophthalmology related disorders. And I was a pediatric ophthalmology fellow in the NICU when I saw the medical geneticists come in and make their diagnosis. And I thought that's really cool. Instead of running around looking at babies' eyes, doing the retinopathy of prematurity eye exams, I thought the geneticists had a cooler job of putting together the puzzle and making an accurate diagnosis. So I jumped boats and became a medical geneticist. And I was at Emory prior to moving to UC Davis, where I'm currently. A clinical geneticist, and I also have research aspect to my career. So I do precision genomics clinic and work closely with the molecular mouse biology program, where we are doing whole genome sequencing and then making mouse models for targeted genetic mutations. So yeah, a bit of both.
All right. Anne?
So I'm also trained as a pediatric clinical geneticist through one of the combined programs at Boston Children's Hospital. I did MD PhD training before that, kind of a bench biologist, and then stumbled into genetics and fell in love with it. And so I spend some of my time at Boston Children's Hospital, where I have a small research group, and I also see patients in some specialty clinics I've started up around my research interest. But I spend half of my time at the Broad Institute at MIT and Harvard, where I co-direct the large-scale Center for Mendelian Genomics, which is now transitioning into a new program that we're can't agree on a name on, but working with like large-scale, trying to figure out how to diagnose patients and discover new disease genes and things like that. So I really like getting to work on both sides of the field.
All right, and Gareth?
Hi, I'm Professor Gareth Evans. I'm a medical geneticist, clinical academic in University of Manchester in the UK, and I started out after medical school, joined the army, and so a bit unusual. Spent 6 years in army training, mainly doing pediatrics, which actually covered my general professional training, as we call it in the UK, because I did 4 years worth of pediatrics in the army, and very similar actually to Suma. I was on a special care baby unit, or a NICU, as you call it, and I was unaware there was such a thing as a medical genetics specialty. And I'd loved genetics at med school, and I immediately thought this is the thing I want to do. So again, very similar course, and then I got a research job in genetics in Manchester, and I've stayed in Manchester ever since. And I work mainly with genetic predisposition to cancer. Many of you will have heard of the BRCA1 gene with Angelina Jolie, so I do a lot of that, but also predisposition to neurogenic tumors in neurofibromatosis and other conditions.
All right, thank you. Now, some of you did mention in your introductions, kind of like Suma did and Gareth did, about what actually led them to genetics. But for those of you who didn't, do any of you want to say what kind of piqued your interest in genetics and led you into that area?
I'm happy to start us off. I was positive I was going to be an oncologist. I was trying to decide if I wanted to be a pediatric or an adult oncologist. And I knew that I liked working with people, kind of to like having that long-term relationship. And I wanted to be, I liked the kind of figuring out what type of tumor it was and then the treatment plan. But then I found out actually oncology is the treatment plan. Like you spend a few weeks figuring things out and then you spend years treating. And so in genetics, I could actually you mostly are just trying to figure things out. Like there's a little bit of management after that, but it's a lot of like, what is going on here, figuring out the puzzle pieces while still getting to follow with families over the years and then helping them with manage these conditions that the parents become more of an expert than their other doctors because nobody has heard of a lot of these conditions, but they're the same things you learn about in medical school often. So it really tied everything together for me, the relationships, the puzzle pieces, and then often having to take it into the research realm to figure things out.
How about you, Connie? Because you mentioned you trained as a neurologist, correct? So what kind of led you into the genetics aspect?
So my PhD was in molecular genetics and development, and I opted to do neurology because I was fascinated with the brain. But then in my neurology training and fellowship and participating in patient care, there are many of those kiddos with global delay, ID, epilepsy. We didn't have a good explanation for why. And many of the modalities we had to treat were very limited. And so, I sort of harken back to my experience in my PhD, and I looked to see where the field was going. And I thought that this was a great time to pull back on my skills of genetics, be involved in the detective work, I think, that comes with trying to determine the etiology for a lot of the rare disorders. So I think one of the things that draws me to genetics is the detective work, the trying to figure out what's going on here, trying to put puzzle pieces together, and in so doing, improve the quality of life for the patients, even though, a lot of times parents will say, well, can you fix it now that you've identified it? In my world, no, at least not from a genetics perspective, not yet. But it informs parents. They, in my experience, often feel comforted in knowing the cause. They see value in being able to join a team of other parents with children who have similar disabilities and challenges. And that, I think, it brings them hope. And so that's one of the beauties of being in this role. In neurology, and pediatric neurology in particular, at least when I started training, we didn't have a lot to offer parents. But I think now that we have these communities of individuals with rare disorders, that's really advancing our understanding of the disorder and supporting them. So those are some of the things that I have seen that have really drawn me to the field and have kept me in the field.
Wonderful, thank you. Now, I noticed many of you also have PhDs. So can any of you who have both an MD and a PhD kind of talk about what played into your decision to pursue both? What, having that PhD, what does that add to your career and the things that you're able to do? If you can comment, if anyone in the audience is thinking about pursuing both, would you recommend, not recommend? Comments on that?
So I'll try to take this one. I think, and this also is partially a way to respond to the previous question as well. I knew that I wanted research as part of my career. I knew that I wanted patient interaction as part of my career, and I think that this is not necessarily you're seeing a panel where there are a lot of folks who do a fair bit of research as well. There are also people who are clinical geneticists who do entirely clinical genetics as their career. But it is a specialty that's amenable to people being able to split their time a little bit better and divide it out better than some of the other specialties might be. I think that having the PhD and having that training for me has certainly opened doors in terms of the ability to have a research program, to seek out research funding. Some of what you learn in that process is just how do you run a research project? How do you look at a question in a way that you can design? And I use the word experiment broadly because the kinds of experiments I do are on computers. It's not in a wet lab. But how do you design a question and ways to address that question? In many ways, there are great parallels to that, to what we do in clinic. Getting back to the first question of how did I decide upon genetics, I think the field of medical genetics is a bit of a publicity problem where a lot of medical students don't know about this field, which is one of the reasons we're doing a program like this. I actually had some folks in medical school who are medical geneticists who were very good advocates for this field. And so for me, it was not it was maybe I was a little bit of a late decider because I had decided to do a general pediatrics residency, but part of that was to really get general experience and to really be able to explain understand the breadth of what goes on within medicine. The other aspect that I like about genetics is that it is a field where we get to interact with patients. We also get to interact very frequently with other specialists. And so as someone who has very broad intellectual curiosity in this field, I get to work with neurologists and nephrologists and intensivists. And we get to interact with people in all of those specialties as well.
Anyone else want to comment on why they decided to get both an MD and a PhD?
I'm happy to do that. I mean, I've got a slightly odd situation in the UK. An MD is actually a doctorate of medicine, so it is a thesis. So It used to be what clinically qualified doctors did. So actually an MD in the UK is a doctorate of medicine rather than just a plain medical degree. I mean, certainly from a research point of view, if you plan to do research, I think it's vital to do a thesis. Nowadays, that would always be a PhD, I think, for full recognition. And that it does give you that ability to think for yourself, to be able to figure things out, and how to write. And I think it's absolutely invaluable. It's not absolutely essential if you don't intend to carry out research in the future, but I think it's a great part of training anyway. And certainly in terms of getting a job in the UK in a genetics department, it would be expected that you would have done a thesis or have done some research to show your commitment to the field. And for me, doing a thesis in my condition, neurofibromatosis type 2, has given me, worldwide ability. I, get half of my invite to talk on NF2. So it gives you that chance, particularly if you go into a niche area, of becoming, pretty much a world expert in that area. So I would very much encourage it. But again, if you're not intending to do research, it's not essential.
All right, now you guys saw that we have a number of undergraduates on the line, or people who have just recently finished undergrad. So if you could talk to us about what was your experience, you've just finished undergrad, then what did you do? Did anyone take a gap year? Did you all go straight into school? How did you decide what to do right after undergrad? And I'll start with Maya.
Oh, so we have quite a different medical education system in Australia, which I can talk you through just so you can just think about the differences. So once we finish our schooling, we can actually go straight into medical school. It's a 6-year course. After that, we're all expected to do 2 general years where we rotate through everything from intensive care to emergency to obstetrics. After that, for those of us who choose to do pediatrics, it's 3 years of pediatrics followed by a big exam. And then I chose to subspecialize in genetics, which was another 3 years. So it was a total of 8 years from graduation. But I think, when I think about you guys and I think, wow, you're all kind of embarking on medical school and already thinking about your specialty. That blows my mind. But I can see that you choose that path very early. And it is worth putting a bit of thought into. And all the things that the others have said about why genetics is appealing, I think applies to me. The only one thing I'd add is the breadth of what you see in genetics from all systems, whether you're interested in eyes or whether you're interested in limb abnormalities or neurology. You can see it all in genetics, or you can choose to focus on one. And the breadth of that age range. So to be able to sit with a pregnant mother and to talk to her about abnormal ultrasound that has indicated that perhaps the baby has a genetic diagnosis, and to be able to be there for her, right through to seeing an elderly patient who wants to know if he has a genetic condition that hasn't been diagnosed. So I think just that breadth for me was the most appealing thing. Especially as I felt that in some specialties, I felt it was a little repetitive. There was a little bit of kind of seeing the same problems over and over. So sorry, I've gone off track a bit, but
that's okay.
But yeah,
conversation.
It is. So I just thought I'd put that little plug in for genetics.
Okay. We have gotten a question in from the audience. So if people would like to comment, what is your perspective on the profession of genetic counseling? Can you comment on the choice to pursue clinical genetics versus genetic counseling, if that had ever come up for any of you?
I can comment on that, Erin. I think the genetic counseling program is a great way to be practicing clinical genetics. And it's really an upcoming field, I think. All of our genetic counselors, including Erin here, are very knowledgeable and I think have a lot of fun doing a lot of different things that most clinical geneticists also do, except for the physical exam part of it. The training, though, is a huge difference. It's 2 years after undergrad for the master's program, which again, I think Erin can comment more on. But for a clinical geneticist, it can take up to 10 years. So, like I think it's a decision between what you would like to do in your life and how you want your life to be. That would be the main deciding factor between, like becoming an MD clinical geneticist versus a genetic counselor. And I think Erin may add more to that in terms of if she misses anything, not being a clinical geneticist.
I mean, I think Suma brings up a great point. I mean, for me, the biggest differential was the time commitment. I was just not interested in spending that amount of time, like Maya mentioned, up to almost 10 years. That was the deciding factor for me. I prefer to go to the shorter program. I mean, obviously there are differences in, the highest level of practice in each of these different specialties, but I think it's just really, like Suma said, what you find most important, the amount of time you're willing to devote to your studies and things like that.
Yeah, I'll add a few things to that. I think, first of all, one of the best things about being a medical geneticist is being able to work with genetic counselors. I think they're great colleagues. I think that in terms of the differences, training's a big one. And I've had people say, gosh, I've had medical geneticists tell me, gosh, if I knew that genetic counseling exists, maybe I would have done that. But I think what often happens is that genetic counselors may tend to specialize a little bit more in terms of an area of focus, either prenatal genetics or cancer genetics, and maybe focus even within cancer genetics on a specific area. So if you think you might want to generalize a little bit more than that, then maybe medical genetics is a more appropriate route to go. That being said, a pediatric genetic counselor is going to see general pediatric genetics and work with a medical geneticist for that. Other potential benefits of genetic counseling, if you really enjoy that patient interaction, then they're often the first one, and sometimes they're on the bookends of the interaction with the patient. Sometimes with the post-visit counseling and pre-visit counseling. So that might be something that might push you in that direction. Again, these are both excellent career choices, and I think that's an important thing to emphasize. And it's almost hard within a 30-second or 2-minute or however long I've talked so far to characterize the differences between them, but it is something that is worth exploring, that those differences if people aren't sure about which of those they might want to proceed with.
I have a few things to add that kind of ties in with the PhD too in some ways. In some ways, it's kind of what you want to be able to do at the end of the day. So it is actually hard to have an academic track position like Erin does with the genetic counseling degree, not impossible, but there are handfuls of these available in the country. So that's certainly not the normal track through genetic counselor training. Just like it's not the normal track through MD training that you run a large research operation necessarily afterwards. So a lot of genetic counselors have to be supervised, can't get licensed for independence depending on the state they're living in. So it just depends if you kind of are happy always working on a team and kind of contributing to the team project. It can be great because there's a lot of the stress and overhead you don't have to worry about, which can be really nice. But if you want to have a little more independence, like that's the MD definitely gives you that. You're very much on the hook for a lot of things, but also have a lot more of the responsibility, which can be exciting. The PhD was interesting because it slows you down in training, but then once you kind of have it and finish your training, like Dr. Evans said, he was like an expert and got invited to all these things. Similar thing with me, that I kind of got catapulted at the very end of my training, that it felt like what I could do having both research and clinical training together put me in like a really nice spot. And I've seen a lot of other MD PhDs do the same. Whereas when you finish MD in clinical training, you have to kind of try to build that expertise over time. So none of those are right or wrong. It's just different paths for different things.
Yes, those are all excellent points. Why don't we move into if you guys could comment on what do you, again, going back to like, I'm an undergraduate and I'm just about to embark on this adventure. What do you think made you a successful applicant to the programs that you ended up starting with? What about you, Connie? What do you think made you a successful applicant? What made them choose you?
So I think some of the values or the valuable things to engage in as an undergrad before applying to medical school is to participate in activities outside of your undergraduate training program. So for me, I started research in undergrad, but I also did a summer research project at another university. I also, in my transition from medical school to residency, I did electives outside of my home institution. And so I think it's important to demonstrate that you are able to function in a number of different environments and do that well. And so I think that was one of the things that sort of set me apart in the various groups. In med school, I got accepted into the MSTP program. So I think that also did well for me when I transitioned from med school to residency. For those of you who don't know, the MSTP program is the Medical Scientist Training Program, and it's funded through the NIH.
Anyone else want to comment on what they think makes a successful medical school applicant?
I mean, I would say communication, being able to communicate. So, you know, ideally, you know, I mean, obviously, I'm not medical school in the States, but I think it's pretty transferable. That showing your commitment earlier. So obviously, working in hospitals, helping out, doing all those sort of things that show commitment. But a lot of medicine is about communication. So showing you have the communication skills and demonstrating that in the interviews is absolutely vital in my eyes.
Okay, I can take that question too and comment on, other than your grades, you have to have at least 3 really important things that you can talk about in your extra activities. And for it to be meaningful and to have an edge over other people, what you need to do is to have that commitment. For example, if you're doing a rotation or a clinical observership with anybody, make sure that you have it for at least over a period of 6 months. And then at the end of the rotation, you should be able to get what did you get out of it? Like an examples would be getting a letter of recommendation, having a poster presentation. It doesn't matter if it is regional, institutional, or if you're able to get a national presentation, that's awesome. But, you know, at least to try and get something out of it, like a letter of recommendation would be awesome. Doing one voluntary activity where you show that you are committed to have patient care or people care, where you are interacting with people, because that shows you are interested in interacting with people and you have committed your time to whether it be food drive or going to, you know, like an elderly care home, whatever it is, it doesn't matter. Even if it is like a paid position, showing that and then getting again a top of the notch recommendation letter that would say that you're the best. No, I'm kidding. But to get a letter of recommendation from your supervisor recommending your work. So have 3 of those. Instead of doing a 1 week in El Salvador or 1 week in India where you have gone and served somebody, that honestly doesn't count. So a more committed, at least 3 to 6 months activity. If it is longer, like a 2-year period, it's even greater. But do rotations, at least 3 of them, because that's what's entered into the medical school, most, or at least the ones that I'm reviewing, which would tell you that you are a better candidate than the next one. And then I think keeping up your grades and other things, MCAT scores goes without saying. Those are screened out by the computer.
Well, that's excellent, guys. Is anyone else involved in medical school admissions that wants to comment on specific items like that?
I don't know if it's a specific item, but I think one of the important things about that prolonged experience and multiple experiences is that it lets us know that someone knows what they're getting into to some extent. You know, I think a lot of times what we're worried about is folks that might have a perception of what a medical career might be like, and haven't experienced it enough to know if it's right for them. And one of the best ways to do that is to have a prolonged experience. It doesn't have to be. It doesn't have. And I think someone earlier mentioned it was surprising that people have decided as early as, you know, thinking about when they're applying to medical school what their specialty might be. I certainly was not that way. I was all over the place about thinking about what I would do. But what helps is to see that someone is taking steps to try to figure that out.
It is really hard to get into medical school, and I just kind of feel like you're expected to be the best at everything, but there are like principles of what they're looking for. They're looking for people, again, just reiterating what's already been said, they're looking for people who are committed and who have endurance, because medical training is hard. And so if you're not going to make it through, it's a huge cost investment to invest in that training. There are more people who apply. They want to train the people who are going to finish the training and use it. They're looking for people who are really smart. That's like, you know, you want your doctor to be smart. I mean, you just do. Like, your medical care is in their hands. And then they're looking for people with leadership potential. And that doesn't have to be everyone, but that, you know, their medical doctors are often leaders in things. And so that's why they're wondering, even if you know, led on, been the team captain on a club sport or something else, they're looking for your leadership potential. So you're trying to showcase some of these characteristics through your CV and through the things you've done. So it's not that you have to do a million things a week of each, although if you want to go to El Salvador for a week and have a great life experience, definitely do that also. But the things you should be highlighting on your applications are that sort of showcase these kind of qualities.
Awesome. Now, in the interest of full transparency, we all know that, you know, choosing this as a career path is a great financial investment. And so I do want to add, you know, just for the benefit of our audience, as you feel comfortable, if you want to comment on how you approach that aspect of your training, you know, were finances a consideration and what you ultimately opted to do? How did you choose to deal with that? Again, as you feel comfortable.
I can just make the comment that I don't think anyone chooses a career in medical genetics because they're motivated by finances. I think that you have to dig deep to find out what motivates you, what satisfies you, what drives you, and if that is, you know, to be financially rewarded, then I think that's fine. But I don't know that medical genetics would be the right path for you.
And to clarify, I mean more like, how did you decide, how did you pay for school? How did you overcome the initial sticker shock, if you will? If that applied to you, maybe it didn't.
Australia is a great approach, actually.
So in Australia, we don't have to pay anything to enter university. We have the option of paying as Australian citizens, or we can defer it to our tax. So when I started working as an intern, a portion of my tax went to paying for my university fees. And then when I earned enough, I had the option to pay it all in one lump sum and have a little tax benefit. So
for those of it, for everyone with international perspectives, I do think they are relevant here. We do have a number of audience members who watch this as a recording from other countries. So feel free to say, you know, whatever is your truth, because it will be relevant to someone. Don't think we only care about US here.
Yeah, in the UK, it's not quite as good as Australia. We did start having to pay for our med school, so it will be about I guess about sort of $13,000 a year to do med school for 5 years. I think for a foreign student, it would be a lot more than that, actually. But so for us, it's about 13,000 a year, which you have as a grant, and you then pay that back as you earn over a certain amount. So it would be relatively straightforward in the UK to pay that back. Ironically, of course, we get a lot of medical students who qualify, go abroad to the US and Australia and never pay any of it back. But there you go. That's one of the benefits of our system. Yeah, there is a cost involved, and it's not minimal. But in the UK, you wouldn't actually have to pay that yourself. You'd get a loan to cover it, and that loan, if you never earn any more, so if you never practice medicine, you may never have to pay it back.
And someone from the US wants to comment?
So the MD PhD program, I wouldn't say part of it, but the part of the way they allow people to do that training program that's 8 or 9 years between the 4-year MD and the 4 or 5-year PhD is that it is subsidized as the MSTP programs that Dr. Smith-Hicks mentioned, that it's funded both to cover your tuition typically and a stipend of $30,000 to $35,000 a year. And so there are people who think, oh, well, MD PhD is a financially better decision. I should try to do something like that. But it really isn't, because even if medical school costs $50,000 or $60,000 a year and you add on $30,000 to $35,000 as your stipend, when you think about it, it's going to take you 4 or 5 years longer to get out of training to start earning a real salary. That amount of money is not going to be more than your salary is going to, like your loss from those 4 years of extra training versus working in the medical field. So there's no like financial true benefit to doing that. I mean, we do come out that we finish training much later than in age than our colleagues that we started with, and we don't have the debt, but there are good loan programs in the U.S. I don't know if anyone here has enough loan that they're willing to talk about. I mean, again, I went through the MD PhD program. That is one of the benefits of it. I am still paying off my undergraduate loans, but I'm almost done with those finally.
So that's exactly the kind of information I think people are looking for. You know, they're trying to decide what kind of program should I apply to. And I mean, that is, at least in the US, it is a consideration for people, you know, how they might want to pursue it. So I think that's really great information. Thank you.
You need to love what you do. It's hard training, but if you love doing it, it makes it all worthwhile. So you don't want to do something just for a financial decision if you don't love it.
Awesome. A question coming in from the audience. Could you walk through a typical day, including, you know, obviously some of you have research commitments, so you might not be seeing patients every day, but give us a special focus on when you do see patients.
Is that pre or post COVID? Because it's actually changed things a lot. I will go with what we hope things will be back to before too long, and have other people fill in for this. So in some ways, it actually, I'll talk first about when we see folks in adult genetics and general adult genetics. Usually the preparation for seeing the patient starts before seeing the patient. We will have had a triage process with referrals where we try to make sure that they're being seen in the right clinic, right? Is something really is an adult genetics problem and not something that should go to a different specialty. We'll try to get as much in terms of records available ahead of time so we can review those and make the appointment efficient. And then typically for our general adult genetics patients, a genetic counselor is the one who goes in and sees them first. Because I'm an academic medical center, there are a lot of trainees that we work with. Sometimes it's a genetic counseling trainee, sometimes it's a medical genetics resident, so they would be involved in different parts of the care. Typically, the genetic counselor will get the initial overall medical history, somewhat usually focused towards the questions that are at hand, and family history, and then come out and discuss with me. And we would go back in, depending on how busy we are, either go back in together, or maybe the genetic counselor is going on to the next appointment, depending on how far behind we are. And at that point, meeting with the patient and asking any additional clarifying questions, doing a physical exam, to try to figure out what's the appropriate step to do here. Is this something that can be diagnosed clinically and we're starting to talk about a management plan? Is this something where we need to do additional studies, which might be genetic testing, or it might be imaging studies, or it might be referring to another specialist to really get their characterization of the phenotype. And typically a lot of what we do, at least in my practice, is not long-term management. It is that initial diagnosis and establishing a management plan, partially just because we don't have enough clinical effort to be able to see folks frequently over time. That's the bulk of the adult genetics, and I'd be interested to hear what other people do as well. For cancer genetics, a lot of those are primarily seen by a genetic counselor, and my role is to supervise genetic counselors and be available for supervise in the medical terminology, to be available for questions that are answered to help set up the strategies for when is this testing appropriate, when do we need to really discuss and look at something that's broader.
I suppose one of the things that's very unique about your day in medical genetics, you know, is just the length of time that you would not only spend with the patient and the family, but the length of time you might spend afterwards in reading. So it would not be unusual to, as we just heard, spend a good hour preparing, getting all of the records, getting the pedigree, making sure they're going to the right clinic, to then spend an hour with the family, and to then spend a few hours reading, because we don't have all of these thousands of genetic disorders in our head. And we're often encountering things for the first time. So to then spend hours reading and perhaps emailing colleagues and sending them x-rays or details and saying, hey, do you know what this is? Do you recognize this disorder? And I think this is really very different to the medical model that you'd be familiar with in most medical specialties. And for me, it was a plus, because I was always in trouble in my emergency rotation because I took too long with families. I really spent a long time and I really enjoyed talking to them. And I didn't do well in emergency medicine for that reason. So genetics is very suited to me because I really enjoyed that, really deeply finding out what's going on, not just medically, but what's going on with that family and being able to be there for them. So that's a very unusual, I think that's very unique to our specialty.
And I didn't mention, but part of not the day, but the week is the conference where we meet with the other medical geneticists in the group and say, hey, I had this case and this is what I'm thinking, but is this something you have seen before? Is this something you're familiar with? Do you know someone who, another like ultra subspecialist that I should email to get a little bit more information about it? I agree. That's part of the challenge, and part of really exciting to me about medical genetics.
I just wanted to add a little bit about metabolic geneticists as well, because they deal a lot with newborn screening. And if somebody is looking at, in quote unquote, doctoring in terms of giving treatment, and if it seems like, oh, we only diagnose and don't treat anybody, metabolic physicians do a lot of treatment and take care of all of the metabolic patients. That includes disorders like phenylketonuria or methylmalonic acidemia, and there are a lot of diseases or disorders that are being added to newborn screening. The other one that comes along as well is called lysosomal storage disorders, where there is therapies with enzyme replacement therapy, where the patients come in for infusions. There is gene replacement therapy as well that is beginning to pick up. I would say a handful of disorders or less than that. So it is a very exciting part of one's career to go from not having any treatment to developing a treatment and then seeing the patient's improvement with therapies. So that aspect is also there. The metabolic training is an additional 1-year training after the clinical genetics training. And some people, especially in the academic settings, have the ability to practice just metabolic genetics, which is caring for the newborn screening and lysosomal storage disorders. And then if you're even subspecialized, you may be doing just lysosomal storage disorders and like doing enzyme replacement therapy and having your research program. So I think a lot of us here again are academicians. So we have a dual role of doing both research and teaching, as well as clinical care of the patients. But in private hospitals, it's rare for somebody to be a private independent practitioner, although there are a few of them around for practicing genetics. So they may be in, like for example, Geisinger or Kaiser or Sutter Hospital or group hospitals like that more commonly. And on-call is also there for genetics, where we do cover, mostly it would be the intensive care units for pediatrics. The NICU and the PICU are the bulk of our referrals when we are taking on-call, and it's a coverage 24/7. We carry a pager like everybody else. We have residents or fellows rotating. If they are not there, then typically the attending geneticists themselves carry the pager. And unless it is metabolic genetics, there is not much of an emergency. The emergency may be like a very high ammonia level or a acutely sick baby in the intensive care unit, where the intensivists may be wondering about, could there be a metabolic cause, because it's beyond what they typically say in the unit.
All right. Well, the time has really flown by. We are here in our final minute of the panel. I just want to remind everyone that this was recorded. We will be posting the recording on our website by the beginning of next week. Again, for our participants who are not able to join us live today. We also have 2 upcoming panels, one focused on research and other opportunities, and then the final one focused on careers that you might take, or steps that you might take before you decide to apply to further studies. But with that, I just want to thank all of our panelists. We really appreciate your time here today. I think you've provided very concrete advice and insight to our participants. So thank you very much.
Cheers. Bye.
Bye-bye.
Thank you.